population health management using quality metrics to drive improved patient outcomes. We're going to pause for just one moment while we have a few more attendees joining us. We will be going over some housekeeping items in a minute, just to familiarize yourself with the webinar control panel. All right. So at this time, first, we want to make sure that you are able to see the right hand of your screen, and if you can minimize and expand the panel by clicking on any of the red arrows in the upper left-hand corner to view any questions or provide any kind of information to us if you'd like to ask a question. Secondly, you could submit any questions using that chat panel, again, located near the bottom control panel. We really would like to hear from you, so we encourage you to ask questions during the presentation, and we'll take time to answer any questions you may have during the Q&A session. If for some reason we aren't able to get to your question, we will respond to you individually after the event. Finally, all registrants will receive a copy of the presentation, a link to the recording, and a new white paper entitled Automating Care Coordination with Health IT. At this time, I'm going to introduce the speakers for today's presentation. First, we have Dr. Richard Hodach. He's the Chief Medical Officer and Vice President of Clinical Product Strategy at Vital. Dr. Hodach has been long recognized as a leader of population health management strategy and is a regular contributor to prestigious peer-reviewed journals such as AJNC, Journal of Population Health Management, HFM, published by the Healthcare Financial Management Association, Group Practice Journal, and more. Dr. Hodach is responsible for providing strategic direction and clinical expertise for development of Vital solutions. He is instrumental in the CMS Innovation Award of $20.75 million grant, which Vital, VHA, and TransferMed received from the Center of Medicare and Medicaid Innovation. Additionally, Dr. Hodach serves on the board of directors of the American College of Medical Quality. Before joining Vital, he held senior leadership positions at Major Healthcare and Accordance and co-founded MedIA. Dr. Hodach has a PhD in pathology and an MD with board certification in neurology and electrodiagnosis, as well as a master's degree in public health. Today, Dr. Hodach is also joined by Karen Handmaker, who is Vital's Vice President of Population Health Strategy. Karen has deep population health expertise gained through a unique combination of private and public sector provider, employer, and payer market clients over the past 15 years. She has held senior roles at leading national care management vendors and benefit firms, and has developed and implemented total population health management programs for Fortune 500 employers. Prior to this, Karen did strategic consulting for provider systems and health plans in the U.S. and in Asia for 12 years. And since 2010, Karen assists provider and health system clients achieve their strategic and quality objectives with Vital's population health suite of products and services. Karen is a frequent writer, speaker, and trainer on issues related to population health and practice transformation in healthcare. Karen has earned her BA in American Studies at Trinity College in Hartford, Connecticut, and has a Master in Public Policy degree at Harvard University Kennedy School of Government. She has completed Lean Six Sigma training at the Institute for Lean Systems as well as for Vital. And Karen is an active member of the editorial board of the journal Population Health Management. At this time, we will begin the presentation. Dr. Hodach, you have the floor.
All right. Good afternoon, everyone. I'm glad you're all here. As physicians, administrators, and care team members, you're probably already aware that the transition to population health and value-based payment is a real game changer, particularly in the markets that have moved faster toward these payment models. I would like to share with you today why it's important to embrace population health, what it means to your organization when you do so. HIT, in many forms, strong leadership at every level, high-performing care teams, and patient engagement are all critical to success. Finally, we want to walk you through an example of an HIT-enabled population approach for diabetes. Next slide, please. This visual reminds me of Where's Waldo? trying to find one character in a sea of people. However, when you apply it to population health and value-based payment, it reminds us that we are, in effect, responsible for everyone in this population and need to intervene at the right time with the right intervention. We'll come back to this concept over and over again throughout the day. Next slide. Every healthcare speaker in the United States probably has their favorite slide to show this problem. Healthcare spending is definitely out of control and far exceeds how fast our national economy and average wages are growing. This is the problem, unsustainable costs, and this is the trigger that has set into motion a series of initiatives aimed at transforming the healthcare system. Next slide. But equally disturbing is the waste that we have in the current system. This is from a publication by Don Berwick in April of 2012 from Health Affairs. We have highlighted the top three reasons for failure. One is care delivery. We're putting money into we're spending money, but quality is not improved. We have failures of care coordination. Patients are seeing multiple physicians for different conditions, but nobody is coordinating the care. And then the third one is overtreatment. Excessive testing, duplication, initiation of expensive therapies that are not needed are just some of those issues. I just wanted to take an excerpt from the paper and kind of read it verbatim because it really is a very important point to make about what's going on. And this is to speak to you as individuals and as a whole. To transform themselves, organizations must reduce two kinds of waste. First, the avoidable waste from tests, procedures, hospital admissions, readmissions that lead to the high cost for employers and consumers. And then second, the internal waste that inflates the cost of delivery. A reorganization of care processes will address both of these types of waste, and you're going to see ways within this presentation to be able to do that. Next one. This paper was published in 2003 by McGlynn, and I think probably we're all familiar with this one. But it came shortly after the Institute of Medicine was published to Error Human and Crossing the Quality Chasm, two major books that started the reorganization process. This paper happens to be the foundation for many of our products, and you are aware of them as well. The data shows that, on average, patients are not receiving care 45% of the time. But just take a look at these conditions. These are the most prevalent and the most costly conditions that we have facing us. If we just hone in on one of them, diabetes, which we'll do throughout this presentation, 53.6% of people with diabetes are not receiving recommended care or adhering to the standards. Now, diabetes, if it's not treated, then you all know well, will result in complications such as heart attacks, strokes, and renal failure. And all of these can be prevented with the appropriate care. So it's very important to be focusing on these conditions and improving the quality of care. Next slide. Just focusing on the sickest is not going to bend the trend. The sickest are the top 2 to 3% shown here at the tip of the iceberg. This has been the focus of care for a long time. There's a need to get below the waterline to provide care to patients before they become catastrophic and high cost. I can assure you from my experience, if you just focus on the top 3%, you're not going to be able to improve quality or decrease costs in the long term. Just below the waterline, for instance, are patients with one or more chronic conditions. This is where the focus should begin. I read a paper by Medicare, I think in November of last year, And this paper showed data for the first time for Medicare patients. 14% of Medicare patients have 6 or more chronic conditions. That's a pretty significant number. And that means they're seeing multiple physicians. They're taking 14 or more medications. They're getting duplicative tests, and they're going into the hospital 3 times more than any other patient. They're the ones that are the perfect people to be managed with care coordination. Next. This slide emphasizes the point that every individual is responsible for at least half of the factors that contribute to his or her health. They have to get involved in the process. And these are things that we know very well. Nutrition needs to be good. Have to exercise, and they shouldn't smoke. Not only do these habits keep people healthy, but they also prevent or mitigate the effects of chronic conditions such as obesity, diabetes, hypertension, and more. The iceberg slide that I showed you suggests that the more we can keep these people below the waterline, the more we're going to be able to avoid spending, and the more we can improve the overall health of the population. And this represents 2 legs of the triple aim. Next. Transitioning to value is a huge change as shown here. But the reality is that most organizations have not reached the tipping point between these 2 views, meaning that most organizations are straddling between different incentives for different cohorts of patients based on their payers, and at the same time they're still rolling out patient-centered medical homes and population health management tools and processes. So people are doing both fee-for-service and population health simultaneously. Next one. Sorry. A great foundation for what's going on out there is the patient-centered medical home. Thanks to the Patient-Centered Primary Care Collaborative, or PCC, there is no debate that the patient-centered medical home has not just achieved liftoff, but it has real traction. There are now thousands of certified medical homes, and they involve single doc practices as well as large integrated systems. They are achieving better quality of care, short-term and long-term savings, and gaining broad public and private sector support. Next. This shows a recent slide from Health Affairs as well, showing the progress of ACOs from their inception back in 2011. Initially, it was about 123 that were announced at the beginning, but now in this latest survey, we have 606 HCOs that are out there. The number is increasing, and as you can see from these different lines that involves hospitals, physician groups, insurers, and others. So if there's not an ACO that you're aware of yet near you, there's probably one coming, around the corner very soon. Next. Being able to scale is also extremely important. No more pilots. This is what things are going to be looking like. There's a number of quality initiatives taking place across the country at the national, the state, local levels. It involves Medicare, Medicaid, and commercial insurance. I mean, this is really good, but without technology, physicians and care teams, can become overwhelmed with the number of standards to track and improve care. Technology is going to be needed to be able to take care of all the patients with these conditions in the population. Next. And this is an interesting slide that puts together multiple papers. And even though 2,500 may be an ideal patient panel, some research has been done, and we collated it here. But based on a 2,500 patient panel, these published papers suggest that a physician would probably spend 24.8 hours to manage the chronic, the preventive, the acute, and the social issues of these patients. It's just not going to happen. And as quoted by a man familiar to all of us, working harder is the worst plan. Physicians are going to increasingly need to lead care coordination teams, models after high-performance teams, and all members of the team will need to function at the top of their licenses. Much of the work that care teams are doing today is not top of the license. We're seeing people that are looking for data, creating reports, leading voicemails. This is a lot of non-value-added manual work when we talk about lean technology. And in whole or in part can be replaced with the intelligent use of technology applications. And we'll start to show you some of those here shortly. Next slide. This paper was published last fall by the PCC, and it was a paper on showing HIT. But as this table of contents will show you, HIT in many forms, not just EMR and big data, is fundamental to achieving population health objectives. And as you can see from this list of HIT tools, the recommendations that are being made really tie to the functional needs of care managers and the high-performance teams that are evolving as we speak. Knowing the patients, you need to engage. Tracking and taking action on the patients to engage them. Tracking the results and looking at aggregate results to improve quality overall. Next slide. And then lastly, this slide is a vision of how population health might look in the future. This is a population health model that has HIT deployed in many ways, including analytics and EMRs, but also as important, communication between providers, patients, messaging, and the mobile health applications is also very important to this future model. And with this, I'll end my initial presentation and turn it over to Karen, who will describe the bottom-up approach to improve quality. Karen?
Thank you, Dr. Hodach, and hello, everybody. I'm glad to be speaking to you again today. The bottom-up model that you see here, we're going to talk about parts of it for the next few minutes before Dr. Hodach talks about a case study for diabetes in which we're going to be applying these ideas. But want to make sure that everybody really understands the importance of this pyramid. Overall, hitting the bell on quality measures requires what, as I said, we're calling a bottom-up approach. And I'm sure, as you all realize from your own experiences, this starts with a foundation of data that everyone trusts. And then from that trusted data, you can provide a line of sight to the organization's baseline and goals, so you can constantly see how you're doing, not just annually or quarterly. And Dr. Hodach is going to show some examples of reports that can do that later on. You also then need to, going up the pyramid, enable care teams to target and manage patients. And, of course, you must engage patients in their care, recalling the slide that Dr. Hodach showed you where over half of care gaps could be managed by patients managing their own health in a better way. And then the quality improvement aspect comes in with the ability to continue measure your progress. Next slide, please. Some of you may be in MSSP programs or other ACOs. This slide is about the Medicare ACO 33 measures that participants must meet in order to be eligible for shared savings. In year one of the programs, most of you know that the ACOs only have to demonstrate that they can actually report on these measures. But in years 2 and 3, most of these measures must meet benchmarks. So performance is the bar, not just reporting. And as we will see, despite issues still being resolved on the performance benchmarks themselves, although actually now they've been resolved, although there's going to be some new changes for next year, meeting each measure requires care teams and patients to do a lot, and many of the ACOs we work with are looking for assistance. Next slide. So here's a few measures that just to give you a taste if you're not familiar with the ACO measures or if you've never really deconstructed them. So all of these measures require EMR data. They cannot be built based on claims data that the payer may already have. So this part is challenging for practices if they don't have the reporting systems, and certainly the payers don't have the data to do it. So, for example, for BMI screening and tobacco use, which is one of the measures, many practices don't have structured fields to capture the required follow-up activity. So once you determine what a patient's BMI is, you are required to capture some intervention or some recommendation for that patient if they are over or under a BMI standard for their age and sex. So that needs to be captured in such a way in a structured field that could then be reported. Similarly, with tobacco use, the same idea. If a patient is a smoker, you need to be able to capture that you have indeed counseled them or prescribed a medication or something that suggests that you're helping them do something about that condition and then be able to report on it. The diabetes measures are worth pausing on, though, because, and this is not necessarily how it works in commercial plans that have pay for performance or other quality measures, structures that, that participants are held to. But here in the ACO world, these are a composite measure, meaning that you have to achieve all 5 of these measures for every given patient in order to score. So thus the name all or nothing. And in order to do this effectively, you need real-time information on all your diabetes patients and have initiatives to bring them in for appropriate visits and testing. But perhaps hardest of all is to engage with these patients to help them improve on their A1C, their cholesterol, their blood pressure, et cetera, because ultimately the patient has to do what is needed to reduce or improve their own health that will show up in these measures. So just want to just have a slide in here that shows that CMS knows that these are hard, and they provide examples in some of their own documentation that gives some sense of how you can report to be successful. Next slide. And the discussion about data integrity would not be complete if we didn't talk about patient-provider attribution. Many of you might, chuckle at this, that this is a process. The front desk should confirm the PCP for every patient. But as we know, that's not where it ends, and sometimes it all doesn't get completed there either. But the reports that we're talking about, in order for them to be trusted by the providers and in order for them to be useful for that line of sight that everybody needs to how we're doing on these measures, it's really critical that the PCP and patient attribution is not only established up front but continuously maintained. So let's summarize this idea. Some lessons learned on improving data quality. As we just mentioned, provider attribution. Then existing data capture. It's really important to use consistent locations for structured and scanned data so that when you are pulling the information out of your EMRs to do the reporting, you're capturing all of it and not leaving some data behind in an area of the EMR that no one tends to think about for having that relevant information. And then new data capture for measures like we were talking about for the ACOs, where a lot of folks don't have a structured field to collect certain things in. And other examples would be having conducted a falls risk assessment or a depression screening, or even whether a particular drug was prescribed for patients with particular conditions. It's really important to work with your teams to create the structured data field and the companion workflow so that care team members will use that data field to collect the information as they're working with patients. And free text, I didn't mention this earlier, but free text is a big problem. It's not a structured field. It can't be reported, even though there are some very advanced technologies out there that are beginning to try to use free text. But in the meantime, we all need to work hard to minimize the use of free text and use structured fields for the key features of the measures that we have to report on. And then the biggest lesson is none of this can be done just once. It has to happen continuously. So data cleanup has to be part of the culture and the specific roles of the practice and the care team. Next slide. Okay, if you can think about that pyramid that I showed you a few slides ago, we mentioned that enabling care teams is very important. So care teams and workflow design redesign are very fundamental to the transition from volume to value. And this is a real slide, a real-life look at one of our customers in the midst of redesigning workflows and applying technology. This was their starting point. And the current state was very manual with lots of phone calls and lots of walking around the office. Next slide. Okay, so in order to move from checking the box to sustainable PHM, population health management, people like yourselves need to be engaged and take charge. You need to identify an owner to drive and maintain change. And you need to form care teams to include all practice resources and then think about how you could map various roles to the resources you have. In some practices within your organization, you may have a different configuration of roles, of staff, and you can apply or amend or modify roles to meet and match up with the resources you have. And then we're finding that many, many organizations are applying lean. They are using training for lean technology to design out waste, to design in population health management, to leverage automation where it makes sense, and to continuously put in the hands of the care team actionable information rather than having care teams having to look for that information themselves. Next slide. The vision that many primary care practices are trying to implement is illustrated with this graphic, and Dr. Hodach is going to build on this a little bit more in the diabetes case study. The first thing is to be able to profile your population by risk cohort and then determine where to allocate your care team resources. Again, practices are using Lean Six Sigma and a wide variety of automation tools to enable the right workflows for each patient cohort. This stratification model may be familiar to you, like many use the AAFP model, but implementing it is much more probable when practices have the reporting capabilities to do it and keep doing it, and to know they are managing the right patients in the right way. This table also recognizes that some patients don't need visits or time with care managers. Rather, they may just need reminders to get their yearly testing done or to stay on track with their lifestyle changes, while other patients, particularly those with multiple chronic conditions and other risk factors, need more intensive support of the care team. Next slide. This is another view of the care team roles in a redesigned practice, and you can see that each team member's role uses automation to identify, track, or communicate with patients in the ways that are relevant to his or her role. Next slide. So one of the things that is really notable, and this article was published not too long ago in the Annals of Family Medicine, that the stresses and growing pains and challenges that practices are feeling today are alleviated a lot when they go through, admittedly, the hard work, but the fun work in many ways of redesigning their practices. And there's lots of ways that that practices now can actually become more joyful to work in when people have the right tools to do their job. And in many cases, as these arrows are suggesting, there's lots of ways that tools like the ones that we offer can, in fact, leverage health information technology to make everybody's job a lot easier and take away the manual work that was non-value added, as Dr. Hodach described. Next slide. Okay, so now we're talking about patient engagement, and indeed many people call this the Holy Grail. We all know how hard it is to change our own behavior. It's sometimes easier, but sometimes harder to change other people's behavior. So one of the things that's a big challenge in healthcare is that we're very used to as healthcare providers and care team members to be thinking about what our agenda is for the patient, whether it's medication adherence or participation in their physical therapy or eating right or having a living will. But we sometimes forget that in order to achieve any of our agenda for the patient, we need to take into account the patient's agenda. So this patient might indeed be thinking about other things that don't have a whole lot to do with his specific healthcare goals in the short run. But if we were to help him deal with his grieving or his transportation issues or the side effects he's feeling from his medications or his goal to see his granddaughter get married, we may be able to help him better to achieve his goals. And I'm sure many of you are familiar with the challenges and some of the tools and skills that people are developing to be better at this. So let's go back a bit to automation on this next slide. Automation is a very powerful propeller for patient engagement, not so much because it's automation, but because the automation allows us to go below that waterline and find all those people that need attention. So in this peer-reviewed journal, the Journal of Population Health Management, we published an article that shows that automating the identification and the outreach, the telephone calls to patients who are missing an appropriate chronic care visit and the associated test, such as an A1C for diabetes and blood pressure recording for hypertension patients. These folks are more likely to have the visit and the test if they receive an automated call versus those who are not called at all. Without this technology assist, it would be a very manual process and a very costly one to identify and call all of the patients that automation can cover. Next slide. Another really important thing to think about, many of you might have experienced this in your own practices. You might get a report or generate a report that says that your A1C, the percent of your patients with an A1C greater than 9 is increasing, and you scratch your head and say, how can that be? We are looking for all of our patients who have an A1C greater than 9, and we are calling every one of them, and we're talking to them, and we're coaching them. So why is it still going up? This makes no sense. Well, again, go to the next slide, please. We did some more research, and we determined that in a paper that was, again, published in a peer-reviewed journal, that you need to continuously monitor the A1C levels of all patients, not just those who are already out of control. Most patients with an A1C greater than 9 this year were not greater than 9 last year. In other words, they were below that waterline. In fact, some were actually in control. However, many migrate from one level to another, and many didn't even have a test in the prior year. Another significant finding of our research is that the longer a patient goes without a test, the more likely the next test will be greater than 9. So in order to make a big difference in that trend line that you saw on the previous slide, it is really important to go below that water line, and you're going to need the automated tools to find those patients and reach out to them, perhaps using the stratification model we described earlier. Next slide. This is a visual that we like to show that illustrates how the practice's patient-centric workflows for complex care and planned care should intersect continuously with quality management's role to monitor progress against the organization's goals. So this goes to the layer of the pyramid regarding quality improvement. So it really isn't about a fire drill where you get a list of patients and you say, you know, run and call all these patients once a quarter to bring them in for whatever care gap they have. Many practices don't have many options other than to do that because they don't have the data or the reporting to identify these patients, or they're given lists by their health plan that are claims-based that need to be reconciled with the clinical data in the MR. So it's a lot of work. So that's not what we're trying to get to. We're trying to get to a model where there's a lot of usual care, planned care that's between visits and during the visit that can be handled. There's a special team, again, using risk stratification models that manage those patients who are more complex, that are higher risk. And then, but when those patients are coming in for a visit, the complex care team would coordinate during pre-visit prep and other daily huddles with the planned care team to manage those patients. And then ultimately, the quality management team would work with the other team members and be responsible for tracking performance on specific measures and by payer, and initiates and manages quality improvement projects with the care team. All along being aided by this underlying health IT platform that helps to keep everything moving in a consistent and integrated way. Next slide. So a couple takeaways that I think are going to be helpful and lead into Dr. Hodach's little case study that he's going to talk about in a moment, is that quality really is a function and it's not a project. We often talk about a quality improvement project, and there are such things, but that is, but it has to live inside a quality improvement function. So it's really important that in your organizations that you have a function that is empowered by leadership. It might not have a lot of team members in it, but it certainly has people who are responsible for quality. It is in sync. It works in sync with the organization's payer contracts and metrics. It operates often with a quality committee and that has cross-functional membership, and works to continuously define, lead, measure, problem solve, and collaborate with the people doing the work on the front lines with patients to achieve quality goals. And the quality team and the primary care team share data, tools, and workflows to ensure that everybody has that same line of sight, that the care team can see the same data as necessary as the quality team can see, and that it's all trusted and accurate to the best of everybody's ability. Okay, the next slide. So in this slide, we want to talk about how practices are managing patients and not just metrics, and maybe not even metrics at all. The point is that primary care is patient-centric and panel-focused. So practices really need to focus on populations as they are defined by their provider panels and strive to be payer agnostic. Patients obviously have many conditions and stories, and patients need to change behavior, and patients and are depending on their care teams to be focusing on them as whole people and not just as people with care gaps against specific metrics for specific payer contracts. So the metrics and the protocols help the practice to identify patient care opportunities, stratify them by risk, and then depend on them to apply these guidelines as they work with patients to develop care plans and monitor their progress. And now I'm going to turn this presentation back to Dr. Hodach to talk about how to apply our messages to a sample population of diabetes patients. Thank you.
And thank you, Karen, and here I am. Let's go to the first slide, which shows the population health model. This is where I'm going to start by showing you a model of population health management. And what I'm going to be able to show you is that every step or segment of this model can be supported by automation to make it more efficient and effective. Next slide. 1 and 2 actually represent the definition of your population, as well as identifying care gaps within the population. And here we see that analytics are necessary to be able to do that and to do it in very creative ways. This colorful image that's kind of popping out here is a population of diabetics, and every dot on this screen is actually a diabetic patient. And here we're showing A1C and LDL-C values plotted out on here. If you go to the upper right-hand corner of this slide, it's very easy to see that these patients are the ones that have both a high A1C and a high LDL, and those might be the ones that you would want to send right to a care manager to be able to take action on them. Next slide. Here I'm showing you the stratification of a diabetes population. This is actually one of the clients' population that I'm showing you here, and you can see that there's typically only about 8% of the population with diabetes, but in this particular population there was 10.38% of the population, which was almost 8,000 diabetics. Down below, we can further stratify these diabetics by comorbidities and by the A1C level. Not everyone necessarily has to be seen by the doctor or the care manager, but all of them have to be touched, and that's kind of what we're showing here. Over on the far right, we have 128 people out of this whole population that have both diabetes and CAD and have an A1C greater than 9. Clearly, that combination of features would certainly warrant giving it to a case manager or a care manager that is dealing with the more complex cases within the organization. 128 patients would be a typical model, and they might get weekly calls. As we go further over to the right, we see people in the different levels of the A1C may not get as intense of therapy, but may get monthly calls and may get some targeted campaigns to keep them on track. And then those over to the far left, where they haven't had the A1C test or their A1C level is below 7, they don't need as much attention, and maybe a monthly campaign to keep them on track with the basics of diabetes is something that could be done with technology and may not need a care manager. Next slide. Here's another view of different cohorts within the diabetes population. Different combinations of patients can be assigned to different care team members. Some of these people might be invited into a diabetes class if they have both a high A1C and a high BMI. Some of these that are in between are reached out by a care manager or maybe the medical assistant and given messages to keep them on track. And then all patients who are below 7 and have a very low LDL, these patients also could be reached out with campaign messages that continue to keep these people on track. Next slide. Another important thing to start thinking about, and I know is something that we do mention a lot during the various rollouts of our products, is that the daily workflow of the practice could certainly be improved by doing some preparations ahead of the visit. So if you have the right information, visit prep can certainly be done and be able to help improve the patient before it even become the patient in the door. So pre-prep is a tool that can be done 1 week, 2 weeks, a month ahead of time, and can extremely improve the overall process. Next slide. If we just take a look at this slide, this is trying to show how preparations could be very useful. This slide is actually showing the steps in the process that's typical for diabetes and typical for many of the clients that we meet. Patient comes in for a scheduled visit. The medical assistant researches the patient's labs. They find out that the patient's last A1C was 6 months ago. Now they have to go ahead and write a new order to get that done. That's done during the visit by the doctor, but after the visit, the doctor has to call the patient up. There's a lot of waste that is present in this, and wouldn't it just be better to identify those people ahead of the visit that needed the A1C test or the LDL-C test or needed to have a mammogram or some other type of preventive care, and be able to take action on it before, so that when the patient comes to the office, you're not struggling to find out when they had their test. You're taking action on it and trying to improve their behaviors. So it's a great example of how Lean Six Sigma could be applied to the situation in healthcare. Next slide. And then here, what we're showing is that it's also important to continuously track function. And this has to be done with tools that can show monthly, weekly reports of how you're doing on the metrics. It also needs to show you how you can compare different facilities, different physicians to one another, and be able to use reports to improve or motivate the caregivers and the providers to get the actions completed. Next slide. All right, so I think at this point, what I will do is try to summarize the things said in the three components of our presentation. Take home messages. Next slide. Now, what we have found from many of our clients across the country are that these important lessons. And I'm going to just go ahead and summarize them by taking them one at a time. One of the biggest things is to be able to take a systems approach to population health view. Value-based payment, it changes everything. No longer just the people who are coming through the door. It's people that are in the population that are not necessarily coming to the door that you have to take care of as well. Share line of sight to organizational goals. Some type of communication and leadership within the organization is needed to really push this shift. And it's just not unusual for providers and people of the team to not completely join in this process. So there needs to be leadership to push people, and there needs to be communication amongst all components of that team. So everybody is doing the same thing and for the same reasons. Make population health and management a team sport. Designate champions throughout the organization, and we do see this a lot. Such an individual would really embrace change management, and probably it's not a bad idea to include the patient education, behavior change materials as well. Build HIT assists to enable and achieve full-scale population health management. Configure to the measures, keep the end in mind, facilitate the care coordination workflows. This is going to be a very important part of the success of creating these care coordination workflows. Automate patient engagement, reach everyone intelligently with that tool, and put real-time data in the hands of the front line. Make it actionable at the point of care. And then the next slide. I think what we can do at this point is stop and take some questions.
Great. Thanks, Dr. Hodach. Just a reminder, if you'd like to ask a question, please go to the right-hand side of your panel and type in the question, and we will go ahead and announce the question and then answer them. We'll wait a minute or two for a couple of the questions to come in through the queue. There's actually a couple already lining up here. So the first question, I'm going to pose it to either Dr. Hodach or Karen, and you can decide who to answer. The first one is, what are the advantages or benefits that various stakeholders will realize from population health management programs?
I'll go ahead and say something. I think the advantages of population health for patients, providers, and clinicians, it really comes down to, better health outcomes and reduced costs. And clearly, those two dimensions work together for a healthier population cost. These benefits can have a positive effect for sure.
Okay, great. Another question that we received: in a small practice, who is taking responsibility for the pre-visit coordination?
I'll take that one. Very typically, it would be a medical assistant, and we're finding that that's true in small practices or large practices, that the medical assistant would be taking on increasing roles, and as the practice embraces technology like we've described, the medical assistant is able to minimize or eliminate a lot of the manual work that made it prohibitive to do pre-visit planning in the first place.
Great. Another question is, with the topic of population health, given that you were just talking about the diabetes study, obesity and blood pressure is what people typically think of. Are there any other conditions and issues we need to be concerned about?
Yeah, I mean, these conditions are the ones that most people are really focusing on, right now. I mean, I don't think that there's any group that we've reached out to that isn't focusing on these. But yeah, there are other conditions that will require this. Asthma, COPD, coronary artery disease, congestive heart failure, depression are all conditions that can be approached from a population health point of view. I think that the point that I really want to make about this, though, is that you can't be thinking about a person as going after all the people who have diabetes, or going after all the people who have coronary artery disease, or going after all the people who have asthma. Every individual potentially can have all of this stuff, and when you're thinking about patient-centric care, we don't want to forget that one patient might have high blood pressure, might have diabetes, might have congestive heart failure, might be overweight, may need to decrease the risk of smoking. So whenever you're dealing with population health, we've got to be thinking about patient-centric care. It's all about the patient and not necessarily about the conditions.
Great. Another question that we received: in one of your slides, you noted 45% are not receiving care. Is it really not receiving, or are patients not compliant, unmotivated, or uneducated? Some lack of the socioeconomic means to get care. Some providers are skilled or trained and educated, trained in educating patients regarding nutrition and pointing them to social services. So how do you break down from that figure down from the, to implement the change?
I think I probably agree, that there's many different people that are in that non-compliant population, and part of it are, people who have specific issues that the doctor maybe can't be aware of. But if you're able to see the entire population, at least you'd be able to see that there's 55% of the people that you're managing at a point in time, or you're responsible for with a payer. And you'd want to at least be able to find those people, reach out to them, and at least attempt to get some of them to get into the office or get the care gap closed. So I think reports of populations are going to be very important, as I showed in my stratification slide. You may not have to see all these people, but you may want to figure out what to do for individual patients who fall into certain groups.
Great. Another question: what tools or techniques do you use to get our clinicians to embrace the use of standing orders?
I can address that one. We've worked with a lot of practices, and of course, the governing laws in the state do make a difference for adopting standing orders, but assuming that it is okay in the state you work in to use standing orders and delegate some of this to other folks, then those standing orders can actually be put into the platform, into the system. And so when you're doing pre-visit planning several weeks out, you would be able to see those, and the medical assistant or the care manager would be able to enable those standing orders for that patient. So maybe send out a communication, like an email or a portal message, or a letter that says your lab work has already been pre-approved, and you just need to go to any ABC location to have it done before your visit. Or when the patient comes in, you can just hand all of that to them to be able to get some of that work done right after the visit. So it can be handled in any number of ways, but the trick is don't depend just on the physician to take action on standing orders, but delegate that as allowed to other members of the care team.
Great. Thanks, Karen. The last question that we have time for is, what changes will be necessary for care delivery teams?
Well, I guess I'm a big believer that you have to create a team to be able to manage a population. And there are several papers out there by Bodenheimer that go into this in some detail. But the minimum amount of team would be the provider, a nurse, a medical assistant, and the person at the front desk. And if these people are working together and share the goal and know what you're trying to achieve across the entire population, it can be done. But I think you need at least a team. No one person can do the whole thing.
Great. Thanks, Dr. Hodach. If we were unable to answer any of your questions just due to timing here, we will be sure to follow up with you individually. I'd like to thank Dr. Hodach and Karen for their time today. We will send out the slides along with the recording and a copy of the white paper I mentioned earlier at the beginning of the session, and a communication followed up to you. Just so everybody knows, our next executive webinar series is on Thursday, August 28th from 11:30 to 12:30 p.m. Eastern Time. It is evaluating the baseline measure up, pressure down, presented by Dr. Ashok Rai, the President and CEO of Prevea Health. We'd also like for you, at the conclusion of this presentation, when you log off, to please take the quick survey just to let us know how we're doing. It'll also provide us some insight as to some other opportunities or topics that you would potentially like for us to present on. So at this time, the webcast has ended. Thank you all for attending, and have a great day.